I do appreciate that you've taken the time out of your evening to share this information, which I believe to be amongst the most exciting developments in medicine since the advent of antibiotics. We're using your own cells to help you heal yourself. And I'm really excited about regenerative medicine, PRP, and our technologies because it allows us to ethically and safely treat some of the major conditions facing people as they age in our community. So, first of all, you'll see on the sign behind me the Surecell sign, and that's because I'm part of a Surecell group. Surecell is a group of doctors, nurses, laboratory techs, exercise physiologists, dietitians, receptionists, all working together to share data, technologies, and marketing strategies, which allow us to build a huge database. And that database allows us to know what works and what doesn't work, and how to provide you with better care with less pain. And the key from all this data, which we're going to share with you tonight, is the answers to the questions: what conditions can we treat, and what is your chance of success with that treatment? We, through here at Malvern and our other main clinic in Thailand, have trained doctors from all around the world, from America, Thailand, Mongolia, Bangladesh, Pakistan, China, Fiji, the Philippines, Tasmania, right throughout Asia and even some parts of Europe. Of course, all that is in the past because we can't travel to train people overseas, and indeed they can't travel here to train with us, which has presented a lot of difficulties, but we're now working on solutions. And the main solution that I'm doing with my assistant Bev is to build a database of videos of teaching how to inject. So for those of you who might be doctors or healthcare practitioners who want to train with us in the future, we're now building that database, and we're providing Zoom instruction to overseas doctors for how to learn. We've trained doctors and set up clinics under the Surecell banner in many places throughout Australia, in most states, and also many countries. PRP is a really happy subject. It makes me happy, and it makes a number of patients happy. And you can see these guys are happy because they're getting good quality orthopedic sports medicine care, and they're also getting PRP. And they also, in this picture, just won the grand final, the AFL, a few years ago. And this is a letter from the orthopedic surgeon who looks after the Western Bulldogs, saying, "Thank you for showing me PRP because it's helping the Bulldogs." And indeed, a great many Australian professional sporting teams and athletes are now benefiting from PRP. But I know most of you are not athletes, but we use the same technology that we use for athletes to help people who are just suffering from aging joints and muscle pain. Tonight I'm going to talk about PRP as my main focus. I'm going to talk about what it is, the injuries that we can treat with PRP, the scientific rationale or data that lies behind PRP, and the results that we get with treatment through our database. Now, first of all, this whole field of regenerative medicine is fraught with confusion, and a lot of that comes from the media. It comes from lobbying, and quite often there's a sort of a kickback, and I think a lot of this comes from the activities of some of the overseas companies particularly that are trying to sell stem cells. So there's a bit of a competition between, if you like, manufactured stem cells and what are called autologous treatment. Autologous treatment means that we use your own cells to heal yourself. We're not taking cells from placentas or embryos or cord blood or cultured embryonic cells in laboratories. We're just using your own natural fluid from your blood to create healing. Now, this is very safe, it's very legal, it's very ethical, but it isn't very profitable. And indeed, there's a lot of marketing by the particularly overseas stem cell companies to say that it should all come out of a laboratory. But I believe that's non-autologous treatment is not as safe, is not as natural, and is not as ethical. So as I talk about our treatment, so I want you to make the assumption that everything we do is autologous throughout all the Surecell clinics in all the different countries. Even though we have different technologies in each country, they are all autologous. And I'll just mention there's some really exciting stuff that we are doing in Thailand now. We have an IPS system where what we're doing is harvesting small amounts of skin, just a tiny little piece about the size of a 5-cent piece of skin is harvested, and we then develop from that the fibroblast cells, which are like primitive cells, like stem cells, that we can grow in the laboratory and grow millions and millions of these fibroblast cells that in turn will then produce massive quantities of growth factors, if you like, exosomes. And this technology can then be used by removing all the exosomes and growth factors from the cells, effectively breaking the cells down. So there's no living cells in the remaining fluid. So there's no risk of cancers or anything like that because there's no actual living cells. There's just the growth factors and the exosomes, which are packages of growth factors, which we can then deliver back to the patient. And one of the simple ways of doing that, that's not only simple to deliver but also simple to transport, is to put together a nasal fluid that you can literally squirt up your nose, delivering large amounts of your own natural growth factors that can boost recovery and healing, and immensely safe. So we're now already developed that technology, and we're actually culturing cells currently and through this process in Thailand. Regenerative medicine is a huge field of medicine. It's a relatively new word, and it incorporates basically all the natural alternatives to the conventional medical options of drugs and surgery. Regenerative medicine includes things like therapeutic PRP, about which we'll talk tonight, cosmetic PRP, which I probably don't talk enough about, but I'll just let you know that if you come to the clinic for therapeutic PRP, we can at the same time also do cosmetic PRP. And cosmetic PRP includes treatment of face, hair, scars, and indeed we also have options for using the PRP for sexual dysfunction. So that's erectile dysfunction in males, or for females it can be urinary stress incontinence or vaginal atrophy. Regenerative medicine incorporates stem cells, supplements, and we're very focused on using supplements here. There's a lot of supplements that I think can enhance healing very naturally. Some of those supplements include hormones like melatonin. Lifestyle is very important. We work very closely with exercise physiologists. I have 2 exercise physiologists who work with me here full-time at Malvern, and pretty much all patients that come in to see me who are typical osteoarthritis knee average 20 to 30 kilos overweight, and we basically put all of them within a program to lose weight, to increase strength, to regain balance and range of movement. Diet is also important. Weight loss, to quote David Young, the orthopedic surgeon for the Western Bulldogs, weight loss is the most scientifically validated treatment for knee pain. So we try to keep everyone who comes in with knee pain needing a program, not only into a service with me where I'm injecting them, but also to get the lifestyle, diet, exercise changes so that we can get better outcomes. That even includes things like looking at sleep patterns, because if you're not sleeping well, maybe you're overweight, so you're snoring, maybe even if you add, drinking too much alcohol, that makes it worse. That sleep apnea, bad snoring, leads to tiredness, leads to lower energy levels. When people are low in energy, they tend to eat more. When you eat more, you get heavier, your inflammation levels go up, your pain goes up, then you can't walk so much, vicious cycle. And we also have a hyperbaric chamber here, and I think the best thing is to use the hyperbaric chamber in conjunction with PRP harvesting. And if patients have time, we recommend they do the hyperbaric chamber before we harvest their blood. We've talked about cosmetic. Of course, it's cheaper if people come in, they do the cosmetic and the therapeutic at the same time, but you can, of course, have either just cosmetic or just the therapeutic. And the sexual gynae. Now I'm going to show you a video. We use our videos extensively with patients. All these videos are available on the website, and we find that they save our staff a lot of time because we send the videos out to you before you come in so that you're already informed when you come to the clinic. That saves us time, and also I really like it because I don't like ever talking people into treatment. I like that they come in fully informed already. They've already weighed up the pros and the cons so that my focus can just be on making an assessment of the patient and treating them. And these videos we find are very good as a quick way of giving a lot of information to people. I'll play it.
PRP, or platelet-rich plasma, is a process where a person's own healing cells, the platelets, are employed to heal injuries in joints, cartilage, tendons, ligaments, and even for skin rejuvenation. Platelets are a basic component of our blood that leak out onto injured cells when a vein or artery is ruptured. The cells that are injured emit signals which let the platelets know where to go, activate and release growth factors that start the healing process. PRP takes advantage of this process in a very simple way. A small amount of blood is extracted from the patient, then centrifuged to extract only the blood's platelets and plasma, photoactivated with light, and then injected back into the area of injury. Normally, the body performs this treatment by itself, but sometimes when we get injuries in places where blood doesn't reach well or our tissues age, we can help it by concentrating growth factors and stopping inflammation that can be painful and debilitating. Injured cells send off distress signals, attracting the activated platelets brought in through PRP. The newly arrived growth factors now motivate the healthy cells to multiply and replace the injured or dead cells. The healing process is in full gear. PRP is an easy, quick, low-risk, non-surgical and natural procedure we can use to shorten healing processes, lower pain levels and reverse the effects of aging.
So, summary of the video is that PRP replaces cortisone or Synvisc or hyaluronic acid as a treatment of joints, primarily to delay or prevent joint surgery. Because we know that the more joint surgery you have, particularly clean-up arthroscopes, the more likely you are at a young age to end up with a total knee joint replacement. I think you all know what cortisone is. It's a classic anti-inflammatory that is used by doctors, radiologists, rheumatologists to treat things like tendon problems, ligament problems, particularly golfer's elbow, tennis elbow, rotator cuff shoulder. There are many studies now that suggest that PRP is actually superior to cortisone because the overall pattern with cortisone is that the pain goes away for maybe a month or two at best, but then comes back, whereas PRP allows for regeneration of the tissues so that we don't get a return of the pain because we actually are creating new blood vessels growing into the damaged or scar tissue area. Whereas with cortisone, you actually tend to accumulate scar tissue, which has very few blood vessels in it. It isn't flexible. And so as you strain it and stretch it in sport or physical activity, you re-tear it through the scar tissue where you end up with a permanent weakness in the tendon ligament complex. Synvisc or hyaluronic acid I want you to know about, because many of the studies that we're going to talk about later on in this presentation are based on comparisons of PRP versus hyaluronic acid. And in most of these studies, in fact, PRP is shown to be far superior to hyaluronic acid. The reason we're here is because of the triple epidemics that are affecting people as they age in not just Western society, but indeed in Asia, maybe even more so, where we see people at an even younger age than here in Australia suffering from obesity, diabetes, and osteoarthritis. Now, it's a vicious cycle because basically the heavier you are with obesity, the more pressure goes on the joints, the more inflammation is in the body, the higher the sugar levels. Diabetes causes premature aging of the joints as well, and some specific problems such as the diabetes, the sugar levels cause frozen shoulders, upper limb tendinopathies. In fact, you're 5 times more likely to suffer from an upper limb tendinopathy or frozen shoulder if you have diabetes than if you have normal sugar levels. The inflammation leads to arthritis in the joints, particularly arthritis of the knee. And arthritis of the knee leads to lack of physical activity. And when you can't walk, you prematurely age and you put on more weight. So we need to walk not just for our physicality, but also for our mental health, particularly during a COVID pandemic. This is a vicious cycle because, of course, the diabetes makes the arthritis worse. That makes the obesity worse. My job is to intersect this vicious cycle by sticking needles in your knee. And it's the job of my team to treat the obesity and the diabetes so that you're healthier and live a better, higher quality life. We have 3 secrets. The first is that cells work, and I hope you've already seen enough data, and we'll see further data, that cells, be they derived from your blood or from your fat, are effective at healing arthritis and reducing degeneration and aging. The second secret we have is our diagnostic technique. And indeed, we have a different diagnostic technique to that of most doctors. Most doctors are very dependent on imaging, X-rays, ultrasounds, MRI scans for their diagnosis. And although we look at them and use them as an aid, I think it's important that we still use history as given to us by the patient and physical examination as the basis of an accurate diagnosis of where the pain is coming from. Because frequently presenting patients have a problem where the imaging is not the same as the actual history of pain. The classic example of that, it would be something like back pain, where often patients with back pain come in with a diagnosis of disc disease. And in fact, anyone of my age will in fact have some degree of disc degeneration on imaging. But that doesn't mean that the disc degeneration is the cause of the pain. And in fact, many people who have low back pain, even where they seem to have a classic story of sciatica, which is pain running down the leg, in fact, have the pain coming from one of the ligaments in the back, the iliolumbar ligament, or the sacroiliac joint, which is the joint where the pelvis and the spine join together, or indeed it can come from a troch bursa, which is the bit on the outside of the hip where the tendon runs around the corner of the hip bone. Now, we need to examine the patient in order to differentiate the pain that comes from imaging versus the pain that the patient's actually experiencing. And our key secret here is the use of local anaesthetic. And we use local anaesthetic to inject into the area of tenderness or pain, and then we'll test the patient out, get them to walk, stand up, move around. If the pain is relieved by the local anaesthetic injection into that tender area, be it the bursa or the sacroiliac joint, etc., then that is probably where the pathology that causes the pain is. And I've seen patients booked in for surgery or indeed having surgery on the basis of the imaging where that wasn't actually the cause of their pain. Doctors tend to make assumptions if they look at the imaging first before examining the patient, and I'm meticulous that I always like to hear the patient tell me the story of their pain and then physically examine them before I look at the imaging, because you get biased when you look at the imaging and you make assumptions. And the big assumption is that it's all coming from a disc or it's all coming from some other structure seen. There's a good phrase for this. It's VOMIT. VOMIT is an acronym for Victims of Medical Imaging Technology. And I see at least one person suffering from VOMIT every day where they've been misdiagnosed. The third part of our process is our teamwork. So what we've done is we've set up a process, if you like, the first PRP production line, where we have the receptionists, nurses, doctors, exercise physiologists, physiotherapists, all working together as a team so that my time can be leveraged so that we can provide a service to patients which is affordable. And this has allowed us to build a huge database of over 10,000 patient follow-ups. And that database, which I'll share with you, allows us to better know what we can do, how we do it well, and that allows us to answer the question for you, can we help you? I'm now going to share with you some published papers summarized in a video that was put together a few years ago. It's a fraction out of date, but still relevant.
Welcome to the Surecell Medical Series. In this video, we're going to present clinical research data published on the efficacy of PRP. The idea that blood contains healing properties has been in cultural myths and religious rituals for centuries, but when doctors started using whole blood to treat tendon injuries 40 years ago, the procedure was painful and results were unimpressive. With the advent of PRP, science has finally confirmed what ancient practitioners have long suspected. In the last 4 years, PRP has grown from relative obscurity to acceptance by mainstream medicine, with over 7,000 published articles, an annual growth rate of 200%. Filado did a long-term follow-up study of PRP treatment for osteoarthritis of the knee. It demonstrated that the majority of patients had significant pain relief for 1 year, with almost no decline during this time. This is very similar to the Surecell data collected by myself, Dr. Peter Lewis. Between 1 year and 2 years, there was a reduction in pain relief, but even after 2 years, pain was halfway between maximum relief and baseline. Gossens studied 100 patients randomly allocated to PRP or cortisone injections for tennis elbow. The group treated with cortisone had the quickest initial improvement, but by 9 weeks, the PRP group not only caught up, but went on to better results, while the cortisone group returned to baseline after 6 months. Xrays compared the results of ACP or PRP versus hyaluronic acid injected into osteoarthritic knees. At baseline, before treatment, the PRP group of patients had little more pain than the hyaluronic acid group. After 4 weeks, the PRP group had improved more than the hyaluronic acid group. At 12 weeks and 24 weeks, the gap between the two groups increased because the hyaluronic acid group deteriorated while the PRP group were continuing to improve even though they were not getting any more treatment. Surecell data confirms continuing improvement after treatment, which suggests that the action of PRP is more than just a lubricant or anti-inflammatory. PRP causes long-term healing due to growth factors. Xrays also looked at his results according to severity of initial osteoarthritis. This graph shows a similar improvement in pain scores across 3 grades of severity, which suggests that even patients with the most severe OA will likely benefit from PRP. The last years have seen numerous studies and publications which show that patients feel better after PRP treatment, and MRI scans confirm substantial physical improvements. If you would like to learn more about PRP, please leave your questions in the comments and our doctors on duty will answer them as soon as possible.
So a quick summary of this study. This is the Xrays study from 2012, which a lot of doctors have actually still not caught up with. And it basically showed that PRP is superior to hyaluronic acid because the hyaluronic acid really bounced back if you like, they had the second wave of pain fairly soon after, like 6 months to a year after the initial treatment with hyaluronic acid. The knee was almost back to where it started, whereas the PRP knees continued to improve even though they weren't getting any further treatment. And there are now several meta-analyses like Kanchanatha one, which are pretty much convincingly showing that PRP is now the treatment of choice for osteoarthritis of the knee. In fact, I've been at David Young's rooms where he's had a patient in with OA knee and he's put this article in front of them and said, this is like global warming. There now should no longer be any debate as to whether this is real or not. PRP works. This study proves it. A meta-analysis, by the way, is where a group of researchers look at all the previous studies that have been done and put a weighted value on each of those studies depending on their validity and size, and then basically try to calculate what the truth is by pooling all the data together. And there have been quite a few meta-analyses now because there's a lot of studies out there. Kanchanatha one looked at a total of 551 studies that could be included, and they picked the best 8 or 9 of those. Shen looked at 14 studies, and there's some other studies out now that are increasing the pool even larger. And what they're all basically showing is that PRP works better than hyaluronic acid. It works better than cortisone. In fact, cortisone now in some countries is considered medical negligence in Thailand because we've got so much evidence that cortisone not only does not prevent or delay the advance of osteoarthritis in the knee, it actually carries quite a lot of risks for the very low benefit. And its benefit is only short-term, temporary. And then you're actually worse off than when you started. Through the Surecell group, our friends in Bangladesh, who are unfortunately being hit by COVID really badly at the moment, the head of our clinic and head author of this study that I'm now referencing has in fact been suffering from COVID over the last week or two along with his family. And they have been treated with ivermectin, and I understand that they're really using a lot of ivermectin as a treatment in Bangladesh, and it may be helping keep their death rate down. But certainly the country itself is pretty devastated at the moment, and so is our clinic, which is closed there. But they've performed a very good study looking at a follow-up of 232 patients over a period of a year using WOMAC scores, and they found a statistically significant improvement in pain, function, range of movement over a period of the year follow-up, and very statistically significant, powerful study. We've also done a study in conjunction with Victoria University and the National Institute of Integrative Medicine through our database here. What we're trying to do is that we're trying to make PRP more accessible from the average person. Now, we have some insurance companies that are now funding it, and that includes TAC and work cover. Unfortunately, Medicare is slow to come to the table, but the good news is I've heard that America is about to start funding PRP, and we often copy America. So hopefully we'll soon have PRP funded through Medicare. In China, PRP is already funded as a treatment. Anyway, our study was to try to make our life easier for patients who are trying to get insurance companies to pay, because the bizarre thing is that work cover and TAC will both pay for PRP for the knee, but they won't readily pay without a bit of a fight for all the other joints. And we have staff who spend quite a bit of time just preparing studies and reports and requests for these other joints, whereas the knee is pretty much automatic approval now. So our study design, we looked at all our knee patients, of which we've got like a lot, and compared them with ankles, which we don't have quite so many, but we still have a very large number of ankles. And what we're able to say with a very high degree of certainty is that there isn't very much difference at all between the results that we get with knees and the results we get with ankles. Indeed, our next couple of projects are to crunch all our data for shoulders and hips and elbows, because we know through our database that there actually is very little difference between the different joints in terms of treatment outcomes. And all of the treatment outcomes are statistically significantly better with PRP than for most of the alternative treatments that are available. If you want to look at how PRP works, I believe the best study published on the subject was by Westerlein, American Journal of Sports Medicine. The study was actually published about 5 years ago, but still a lot of doctors haven't yet caught up with it and the implications. One of the myths in the early days of PRP, probably based on the name PRP, which stands for platelet-rich plasma, the myth was that the more platelets you have, the better. So some doctors developed some techniques for spinning and then spinning it again and spinning again to try and get the most number of platelets per mil. And some early studies actually showed that that wasn't effective. And in fact, a 3-fold increase in platelets is often associated with the best clinical outcome, which sounds counterintuitive until you read a study like Westerlein. And then you learn that actually it's not really about the platelets. It's about what the platelets release. Very similar to what I was saying before about our IPS program in Thailand using fibroblasts. It's not about the fibroblasts. It's about the exosomes and growth factors that the cells, the platelets in this case, release. And indeed, there's many types of cells in the blood that release healing factors. The process of spinning the cells in the centrifuge not only concentrates up the plasma by getting rid of the red blood cells, which are not only heavy but also painful and aren't involved in healing, but by spinning the blood, we release the growth factors because we're basically causing a lot of damage in the centrifuge to the cells, and they're releasing chemotactic or messenger signal chemicals that are telling the macrophages, the stem cells and the platelets that are in the blood that are involved in healing. They're saying, hey guys, get active, release all your goodies, help me heal, give me these healing factors like platelet-derived growth factor, vascular endothelial growth factor, insulin growth factor, and growth hormone itself. And indeed, the concentration of the growth hormones that are released outside the cells are up to 67 times higher than is normally present in the serum or the fluid that is outside the cells in your blood. Furthermore, what Westerlein did was he looked at the long-term follow-up over a few days of the growth hormone levels after a single shot of PRP and found that there's elevated growth hormone level causing increased healing throughout the whole body after a platelet injection. So that means that probably not only we're causing this degranulation effect, which is the cells degranulating or releasing their growth factors and exosomes into the serum, but we're also causing a cascade effect. And the cascade effect is a bit like someone in a nightclub calling fire, and then everyone else shouts out fire too. And you get this messenger effect going throughout. And that's what's happening when we're putting PRP into the body. It's causing a cascade of cells saying, hey, healing needs to happen, healing needs to happen. And cells that were in the body are releasing the growth factors along with the cells that we've injected in. Now I'd like to share with you results from our audit, our large study of over 10,000 patients, looking at what we're treating and what our results are like. And the key message that I have for you are, number one, it does not matter how old you are. It's how old the joint is. So we have had some young people who've had lots of surgery, severely damaged joint, who have actually not had good results. And in turn, we've had some old people, even in their 90s, who've had very good results because their knee wasn't too badly damaged. So we want to get to you, or you to come to us, before your joint is completely trashed, because the more severely damaged it is, the harder it is for us to heal you. And in fact, we have developed here at Surecell our own grading system. All doctors are familiar with the grading system of 1 to 4, where 1 is so mild I usually don't even see them, through to the grade 3s, which are a bit of a problem, and the grade 4s, where there is, by definition, some severe damage visible on MRI or X-ray where there is full thickness damage to some degree of the cartilage within the joint. But what we found is the difference between a mild grade 4 and a severe grade 4 is huge. And most of our, we call them now grade 4As, they do very well with PRP. The grade 4Bs do not do quite so well, but still very worth treating. Grade 4Cs have a severe prognosis, and grade 4D is basically hand passed straight to the surgeons, except for a few grade 4Cs that we will treat, but we'll tell them that their prognosis is poor. And that would be people who are waiting to get insurance and just need some temporary pain relief until they get the insurance, or indeed they're waiting on the public lists, which have become horrendously blown out during our pandemic. How do we grade the grade 4 system that we use? Grade 4A has some damage there on the imaging, but they have a good range of movement, not too much fluid in the joint, no significant large joint effusion, and the function is fairly good. They still have some power. The grade 4B can't fully bend the knee, sometimes a bit of restriction in extension. They've lost power and they may have some joint effusion. Grade 4C, they're restricted down to about 90 degrees of flexion. They can't fully extend the knee. They probably have a joint effusion and they're significantly weak. The grade 4D has very restricted range of movements. And their prognosis, of course, is poorer, where at the grade 4As, at least 90% do well. So the other message we have is that it doesn't matter really not only how old you are, what your gender is, the majority of our patients will do well. 83% overall do well. Females, males, very similar results. We have some patients who are celebrities, like James McSweeney, who've come to our clinic and shared their results with us. James McSweeney was an interesting case because he tore his anterior cruciate ligament. Now, normally, a young person would go straight to an anterior cruciate ligament reconstruction, but James McSweeney at the time was 36 years of age and at the peak of his international UFC cage fighting career. And an ACL repair would have basically ended his career completely because he'd have to take the better part of a year off during his recovery and rehab. So I saw him only a couple of days after his initial injury. We were able to put PRP in the knee and drain the hemarthrosis, which means drain all the blood out of the knee. And we did this actually 3 or 4 times over a period of 2 weeks. And he was able to return less than 3 weeks after his original injury to full professional competition. In fact, I saw the fight and he beat his opponent in a cage fight 3 weeks after his original injury. Angelo Gillard, one of the strongest men in the world, a bench press champion, came to us after he'd torn his pec muscle, which is the critical muscle in a bench press. He had done such a bad tear that he actually had on ultrasound a 7 centimetre lump of blood in the muscle. That's about the size of an egg. We treated him very aggressively because it was only about 2 weeks until he had to compete in Argentina in the World Championships in the bench press. And he surprised us all when he actually won the bench press and went on to win about 3 or 4 other events as well and placed in even more. So he did extraordinarily well, and we treat now a lot of powerlifters. This X-ray here is from a lady from Tasmania who came to see me originally 5 years ago, and she come back once a year. She tells me she's 90% better clinically, but more significantly, her X-ray has actually improved. And when we look at the latest X-ray, the radiologist reports the new one as moderate compared, actually, we might just move the projector just a fraction because the really important bit is right on the line. I don't know if you can see that. If we slide it, are we going to muck everything up? Yeah, there we go. You can see a nice gap here, whereas the original X-ray was reported as severe. So when we look at all the different areas of pain, we see that the 53% of all the people who come to see us with knee pain. And that's just because there's more knee injuries around, and certainly in Australia, than all the other areas of injury put together. Although I might say that I think just recently, particularly because of the close work we're doing with some physios, chiros and osteos, we're seeing a lot more back and neck pain than we ever did in the early days of our data collection. After knees, the second most common injury area is shoulders, then hips, elbows, ankles. But we treat a large variety of areas, pretty much anywhere where there's poor blood flow to a joint, or poor blood flow to a ligament or tendon, and you suffer pain, we can stick PRP there. So we're doing thumbs, fingers, temporomandibular joint, and plantar fascias of the feet. This is our pre and post pain levels, and you'll see that the majority of people have more than 5 out of 10 pain before treatment and have less than 5 out of 10 pain after treatment. We've got this very large database which allows us to answer the question, do old people still benefit from the treatment? So you can see here that we've got a couple hundred patients over the age of 80. And what we've done is we've broken all our results down by age group. So this is patients over the age of 80, 70 to 80, 60 to 70, less than 50. And as we look at the results by pain score, the blue being pain beforehand and the red being pain afterwards, you can see that there's very little difference overall in the benefits that young people have compared to the benefits that old people have. We ask questions not just according to pain, because for some patients it's not pain, it's other things like how often can I play golf, or can I still go for a run or surf, or can I cut down on my pain medications. So a good question is, would you recommend the treatment to other people? And again, right across all age groups, we get over 80% of people recommending the treatment. They reported satisfaction and they reported cost effectiveness across all age groups, across all the questions, in a very similar way, a bit over 80% across the board. So across all the different types of questions, whether you recommend it, whether it helped or was cost effective, very similar results. We broke our results down recently for backs and necks, and what we're seeing is, in fact, the backs and necks had a higher pain score before treatment on average than most patients do. They were a 9 out of 10 before treatment, and after treatment the pain had on average come down to between 3 and 4 out of 10. But probably the most socially important value we have, particularly during a pandemic when a lot of our hospitals have been closed, is surgery avoidance. And one of the most important things for my patients is to avoid surgery. Not only because of the health risks of the surgery, but there's a lot of things you can't do on a metal knee, like playing sport and getting full flexion range of movement. And we see that when we looked at the subgroup of a couple of thousand patients who'd been told that they needed surgery, when we broke the results down afterwards, the majority of the patients in blue said that they no longer needed the surgery. Only a minority had to go on to have surgery. So I think that's probably one of the most important things to share with you. Well, now, I thank you very much from around the world. If you're part of our group, please say hello to me through Bev. And thank you very much for spending your time tonight listening to our presentation. Good night.